to this talk on heated, humidified, high-flow nasal cannula oxygen for the Acute and Emergency Paediatrics module for the Master's Programme at BSMS. I'm Carmel and I'm going to talk you through this topic. Heated, humidified, high-flow nasal cannula oxygen is a bit of a mouthful, so quite a lot of the literature you'll see it's shortened to high-flow nasal cannula oxygen, but obviously the heated and the humidified components are some of the crucial bits. What I want to do is go through what it is, how does it work, why some of the limitations can make it a bit tricky, a few practical tips, and then finish off with how we've been using it in our high dependency care unit at the Royal Alexandra Children's Hospital. Here's a lovely little picture of a young lady. You can see she's got a scar down her chest, suggesting she's had some probable recent cardiac surgery and benefiting from the wide bore nasal cannula that are required compared to the usual nasal cannula for HFNC. This slide uses the word OptiFlow, and this is a trademark. So because OptiFlow has the component word flow in it, I think quite a lot of the time we end up substituting high flow with the word OptiFlow in this very similar way that we often will substitute Hoover for the word vacuum. So just to be aware that OptiFlow is not the only manufacturer, there are other products available out there. So we'll firstly start with talking about the four components of delivering high-flow nasal cannula oxygen. And in the picture, you'll see that there are three different types of high-flow nasal cannula equipment. What they all have in common is that they will have wide-bore nasal cannulas that are attached to the tubing. There needs to be the generation of flow, and both of air and oxygen. Now the top right hand corner piece of equipment is the OptiFlow, and that is essentially a simple blender attached to some tubing, attached to a humidifier, and so the flow has to come from piped gases, and that makes it therefore totally static, and you can't use it in a portable manner. So the manufacturer, Fisher Paykel, who are a New Zealand company, produced something called the Airvo, which is the unit you can see in the left-hand side of the bottom two units, and that has its own turbine to generate its own flow. The other thing that you need to be able to do is to be able to blend the air and the oxygen to create your flow and the percentage oxygen. And of course, crucially, you need something to humidify it. The equipment here that you can see uses, on the left, the two left-hand pieces of equipment use a standard Fisher Paykel humidifier, which essentially is really just a glorified kettle. It's the same technology, a heated plate that heats up water and therefore causes it to mist up and humidify. The unit on the bottom right is made by a Californian company, and it's called Vapotherm. That has a different mechanism for humidifying, and it also has its own flow generator, so both the Airvo and the Vapotherm are therefore portable. And the other advantage of the Vapotherm is that it has internal alarms. If flow is interrupted, or the flow is too high compared to the setting, then it will alarm. Perhaps a significant advantage. to the part to talk about the theoretical advantages of high-flow nasal cannula oxygen and how it might work. So the first two things here are about reducing physiological dead space in the nasopharynx, and particularly for very young children, you can see here that in newborns, 3 mils per kilogram of their body weight is dead space of the nasopharynx, compared to a much lower volume per body weight if you're older than 6, which means that you have to clear more air out of your nasopharynx the younger you are in order to do proper tidal volume ventilation and to eliminate CO2. Of course, it also reduces oxygenation if you don't clear that space, and so having flow flushing out your nasopharynx improves oxygenation and reduces CO2 elimination. And you can see the nasopharynx in the pictogram on the top right hand corner highlighted in red. The other element of this is that the inspiration workload is supported by the high flow, so breathing in and the work of breathing in is reduced, and part of this is because the resistance of the upper airway is overcome, and in particular it reduces nasopharyngeal collapse. The space at the top of the green arrow is prone to narrowing and collapse because, particularly in young children, it's softer, there are more mucosal folds, it can become more swollen, and it's relatively smaller compared to the rest of the airway. And remember that 50% of the resistance in very young infants comes from the nose itself, so if you reduce that resistance, you obviously improve the work of breathing. 3 other areas in the way they can help include improved mucociliary clearance, providing the pharyngeal pressure that we just mentioned, and this also translates to pressure inside the lung in the form of PEEP, and a reduction in the metabolic demands of breathing, because you're warming the gas up, your body doesn't have to warm it up, it doesn't have to work at humidifying it. So these are the ways it can help, and we'll talk through these in a bit more detail. So the mucociliary clearance is illustrated in the top right hand graph. This is a very neat piece of work in about 12 adults with bronchiectasis. So bronchiectasis being a condition where mucociliary clearance is affected, and they gave the treatment arm 3 hours a day for 6 days of high flow nasal cannula oxygen, and they made them inhale a radioisotope labeled aerosol to see how well it's cleared, and the dark line shows the treatment group after they received the treatment, and you can see that the percentage of radionucleotide deposition in the lungs is significantly reduced, so they're clearing it. Whatever's been deposited in the lungs much better. And that's clearly going to be not just applicable in bronchiectasis, but pretty much most infections, which are the commonest cause for children to be admitted to HDU. We also know that the pressure in the nasopharynx is increased, and that's relatively easy to measure. It has until recently been quite difficult to show whether the effect on the alveolus and in the lung in terms of PEEP has also been studied, and this paper published very recently showing the relationship between flow and pressure in the age groups of neonates, toddlers, small children and adults, and that's shown in the graphs on the bottom right hand corner. And you can see that the higher the flow rate, so that's the x-axis, the higher the end expiratory pressure, and it seems to make quite a bit of difference if your mouth is open or closed. and for example, in the preterm infant, with flow rates usually used between 1 and 8 litres per minute, the pressure generated can be up to 3 to 4 centimetres if they have an open mouth. But if they have a closed mouth, so the use of a chin strap, for example, then a flow rate of 8 centimetres can create PEEP of as much as 6 to 7 centimetres of water pressure. And you can see how that works also in the term neonate, in the toddler, and interestingly in the small child. So that's usually around the age of 5. The difference between open mouth and closed mouth, so the left hand graph labelled open mouth and the right hand one, small child, is with the closed mouth. And that the flow rates that we commonly use, 1, sometimes 1.5, occasionally 2 litres per kilo per minute, can generate really very high PEEP levels if we're not careful. And one of the problems is that we can't measure the PEEP, and that poses its own difficulty. And just out of interest, you can see there are 2 lines in each of these graphs. That's the dark line showing circles is the pressure generated by flows from the OptiFlow system, Fisher-Paykel, and the Airvo, and the lighter grey lines are those pressures generated by the vapotherm system. So I'm guessing that vapotherm may have had some delight in seeing these results. Moving on, this slide continues the theme of how does it work, and it's been studied in infants with bronchiolitis, where it's known to reduce the electrical activity of the diaphragm and also reduce the work of breathing of all the respiratory muscles. So the top right hand graph here shows on the y-axis the pressure time product in the esophagus, the PTPES per minute, and that's a measure of the work of breathing. And on the x-axis shows what the levels of work of breathing are when using a non-rebreathing mask, when using high flow nasal cannula oxygen, and when using CPAP. So the high flow nasal cannula oxygen, I think, was set at around 8 litres per minute, and the CPAP was set at 5 to 6 centimetres of water. And you can see there's not a big difference between high flow nasal cannula oxygen and CPAP when CPAP is used at that pressure, but certainly a reduction in the work of breathing. And the bottom right hand graph shows that there's changes in esophageal pressure swing. So the amplitude of change in pressure means that the higher the amplitude, the greater the muscles are working to create that pressure. And that by using high flow nasal cannula, so you can see that the left hand series of graphs is on 1 litre per minute, and the right hand one is on 7 litres per minute in an infant, and that the amplitude is reduced, therefore each breath requires less work, and therefore the frequency also seems to reduce. And this reduction in energy expenditure means that it's easier to keep the airways open, and therefore that prevents atelectasis. And of course, prevention of atelectasis is really key in recovering from bronchiolitis quickly with this kind of support. So having covered some of the theory of why it helps, we also need to obviously look at it from a patient perspective and understand a bit more of what it's like. And it seems to be, as you can see in these 2 children, really quite well tolerated. It seems to be comfortable, and you can deliver up to 100% oxygen. It probably is quieter than CPAP or BiPAP through a face mask. It's certainly better tolerated, and appears to be better tolerated also from a nursing point of view than headbox oxygen. There are, with such simple pieces of equipment, some limitations, and the biggest one is that we can't measure the pressure, and if you can't measure the pressure, then it's difficult really to titrate and also to prevent complications as easily as it can be when you can measure. And added to that, we've got the issue that the simpler the piece of equipment, so if you've only got a blender with piped oxygen from the wall and a humidifier, then there are no alarms in the system itself. You're reliant on patient monitoring. If you're going to use piped air and oxygen, then you have to have that available, and you obviously have to have some sort of mains power. So some of the equipment does have battery, and that's beginning to help with portability. It needs to be commenced early, so its advantage is that it's straightforward and simple to set up and to put onto patients, and therefore it can be set up early, but it needs to be set up earlier than, for example, if we were going to put children onto CPAP. And because we know it probably generates PEEP, but we're going to limit the PEEP to between 3 and 5 centimeters of water usually, by limiting the flow rates. And mustn't forget that even though it's a simple intervention, it's simple to set up and simple to start children on it, these are children in compensated respiratory failure on a level of PEEP and support, and therefore they do need a higher level of nursing because of their risk of deterioration. So this isn't something really that I would say that you can use simply on the ward and just stick a patient on it and treat them as if they're just receiving normal wall oxygen. I think that would be quite dangerous. Now, in practical terms, obviously you have to have proper monitoring and appropriate access to resuscitation personnel and equipment, because this is a form of respiratory support in children with respiratory failure. It's really important that we choose an appropriate size nasal cannula. The ideal is that they occlude half of the width of your nostrils. And if you're going to occlude half of the width of your nostrils, you're going to therefore make the work of breathing harder if we do not give enough flow to match the minute volume of the patient. So, two ways you can decide what the minimum flow rate should be. First is a simple 0.5 litres per kilo per minute. That pretty much will equate to matching the minute volume of a child breathing at 40 to 60 breaths per minute, whose tidal volume is around 7 to 10 mils per kilo. Or you can actually calculate the minute volume in terms of multiplying the tidal volume, so that will be 7 to 10 mils per kilo, times the respiratory rate, and that will be the minimum flow rate. And of course, the other important thing is once we started, we're going to check every hour whether it's reducing respiratory rate, reducing the work of breathing, reducing heart rate, and increasing the flow as needed. So I can't emphasize enough that when we're using high flow nasal cannula oxygen, we must remember that the child is in compensated respiratory failure, and make sure that you've got the right type of people and equipment and level of staffing to look after these children. In terms of other practicalities, we would recommend that any additional tubing that is required is within an incubator if it's a baby in an incubator, and that the humidification is set to 34 to 37 degrees, and obviously this therefore also requires that the humidification system is checked every hour to make sure it doesn't run out of water, because if you piped into the nose either warm or cold at that flow rate, you're going to cause distress and possibly nasal burns. We found that particularly if a room is cold, that there is this phenomenon called rainout, where the moisture, the humidified warm air precipitates inside the tubing instead of remaining humidified and going into the patient. Of course, regularly you're going to have to check for pressure damage. And when it comes to weaning, I think weaning the oxygen first is totally accepted practice, and that we certainly would not wean below the inspiratory demands of 0.5 litres per kilo per minute. So if the child needs less than that, we would remove the cannulae. If they still need oxygen, then we would use low flow nasal cannula. The advantage of these kind of high flow nasal cannula bits of kit is that you can add in a nebulizer, and therefore you don't have to disturb the child, you have to wake them up to give a nebulizer through the circuit. And there's a debate between whether it should be distal or proximal to the humidifier. We can use ultrasonic or mesh nebulizers, but the key thing is to reduce the flow whilst the nebulizer is going through, ideally to somewhere near the ½ litre per kilo per minute mark, because that increases the deposition of the nebulized agent inside the lung. We've been using it in a large number of patients, a variety, and as you can see, here's a list of all the types of patients that we've been successfully using it, and I think there's emerging literature about its use in both neonates, children and adults in these patient groups. This is the graph now showing our personal experience of using high flow within the context of paediatric HDU and in the commonest condition that we treat, which is bronchiolitis in the under 2-year-olds. And one of the striking features here you can see is that the blue line, which is the rate of use of CPAP, peaks in the winter of 2013-14 at around just under 70 patients, and then dramatically falls in 2014 to just over 20 and almost just only 10 patients in 2015 and 2016-17 winter periods. And what explains that is the red line, which is our use of high flow. So you can see back in 2009, 2010, we really weren't using it very much. We didn't have much experience, but following our exposure to premature neonates who were coming over on it from the neonatal unit, as they got into the neonatal period, we built up a bit of experience, but we were still only using it in small numbers. And then after 2012, when our staffing levels changed, we felt a lot more confident. It became easier to learn how to use it. And then after 2013-14, you can see a dramatic jump up in the following season, and that's really because we started using 3 litres per kilo per minute and more confidently. And that is a significant reason as to why we've carried on using high flow nasal cannula oxygen at a much greater level than CPAP, and it appears in our unit it has replaced the use of CPAP in a large number of patients who previously we would have treated with CPAP. And if we look at how many patients need escalating to intensive care and mechanical ventilation, despite the change from reduction in the use of CPAP in our unit, we have maintained the low levels of intubation in our bronchiolitis patients. So there's clearly a role that we feel we have demonstrated. This isn't randomized controlled data. This is, need to be mindful that this is just one unit and it's retrospectively collected data, so clearly open to many biases. But nonetheless, when you look at the overall figures and the trends, there's a story to be heard. And just to reiterate, for us that we think it has a role in the use of severe bronchiolitis, where we step up to 3 litres per kilo per minute instead of automatically going to CPAP as the next escalation in our patients with bronchiolitis. So in summary, we've covered some of the reasons as to why it helps and it works, some of the theories and some of the sort of evidence base. I think I just want to highlight the importance of the limitations of the systems and the units, the lack of alarms, the fact that you're treating a patient with compensated respiratory failure, albeit with a simple piece of kit, and therefore from human factor theory you might be inclined to fall into a false sense of security that the patients aren't as sick as they perhaps are because you're using something so simple to help them. And finally, I would say that maybe a potential benchmark we should be aiming for is an intubation rate of between 6 to 8% in severe bronchiolitis, i.e. those who are in a form of respiratory failure with marked increased work of breathing or oxygen requirements who need support. Thank you very much for your time and thank you for listening. I'm going to finish there.